Now, I'm not asserting this happens, and it happens everywhere. I'm just saying this possibility has been recognised, and I've given you 2 examples of studies which suggest some evidence that there may be supplier inducement. Whether or not the supplier inducement is quite likely to be related to how we pay healthcare providers. Both of these examples are examples of what's called fee for service. You do more procedures, you get more money. So in both these examples, that was what was happening. And fee for service as a method of payment of doctors or health professionals, it probably has the greatest incentive for supplier inducement, because there's a bit more of a direct link. More activity, more income. We can compare that with, say, a salary. If the healthcare professional is receiving a salary, they get the same salary whether or not they do 100 procedures or 80 procedures. Or, for example, capitation payment, where you get a payment per patient that you're responsible for. Now, with capitation payments, if anything, the incentive's going in another direction. Do less for them, because that way you can have more patients. And so health economists have been quite interested in this area. Now, let me emphasize, we're not saying that doctors are bad people. We're just saying they're normal. They're human beings. And because they're human beings, actually it's not just human beings, pigeons respond to incentives as well. I mean, there's all sorts of experimental things you can do with pigeons or rats and mice. But let's just think about human beings. People respond to incentives. And I'm not saying that's the only thing that's driving their behaviour, just saying it's one of the factors. And so that's one of the areas that health economics likes to look into. And it's been a particular area for health economists because, as I say, it's just different from the normal model. When we think of demand normally, we think of, we've even got an expression for it, consumer sovereignty. Consumer sovereignty. The consumer is sovereign. They are king or queen. They decide. And that's how we usually think of as demand. But clearly in healthcare, and maybe in restaurants and motor garages and building construction, there may be other people involved in that decision. Now, I don't know if that's coming out very clearly, but this was a big advert I saw in Mexico City. I was lucky enough to be in Mexico City on sabbatical for 6 months. And I was just walking along and I saw this really big billboard, massive. You know. And as a health economist, I was immediately taken by it. I took the picture. Chocolate or boys? Now, there's differences of opinion on this picture. Some people could argue it's empowering of women. It's very much saying women have the choice. They can choose. Equally, I can see how you could see it another way and say, well, this is not actually very empowering of women. For a start, this assumption that it's chocolate or boys, that somehow if you go for the chocolate, your skin will be such and your body will be such that you'll never find a boy. It's also in our modern age. Why chocolate or boys? Why not chocolate or girls? I mean, so you can interpret this picture different ways. I'm using it just in the sense that choice. We have choices. I'm not saying it's always chocolate or boys, it's the choice. To be honest, I don't really like boys or chocolate. But anyway, that's my problem, not anybody else's. So yeah, Choice, that's the other area, informing choices, where health economics has a bit of a role to play. Now, there's lots of choices. It might be allocating resources across different healthcare programs. For example, we've got excellent evidence that oral rehydration salts reduce diarrheal disease in children. Indeed, a kind of, makes it sound like this lecture is sponsored, product placement. A can of Coca-Cola can actually be really quite good as well, but never mind that. We've got excellent evidence that vaccines against Hib work, very effective. We've also got excellent evidence that combination therapy for treating malaria works really well. But of course, we can't do everything, and we have to choose which programs we invest in. Now, of course, in a country like England or Japan, it's a little bit less pressing. We can do a lot of things because we're very wealthy countries. But in the larger part of the world, these are really tough healthcare choices. I emphasize all these programs work, there's no doubt about it. But which ones should we invest in? Well, economics can help you with that decision. And it helps you with that decision, and I'll clarify this next week, but it helps you with that decision by giving you tools by which you can assess the relative costs of different activities and the likely benefits. And once you've got that information side by side, it gets a little bit easier to make the choices as to what we're going to invest in. Or it might be choosing between treatments. So for example, if you're treating metastatic prostate cancer, enzalutamide works pretty well, abiraterone, mitoxantrone, and there's still others that work. Now again, you could just say, well look, if they work, let's make them all available. And that, to date, has rather been the Japanese approach. I say to date because you are going through a sort of, I don't know if it's still called a pilot, but you're engaging in some use of health technology assessment. You're exploring the use of health technology assessment to inform some of these decisions. But for example, a country like England, we don't assume that we will provide all these treatments. We, case by case, I don't mean patient by patient, I mean drug by drug, we make a decision. What is the evidence for its effectiveness? What is the evidence regarding the resource use? Does this imply this represents a good use of resources? And sometimes that'll involve deciding no, not to provide a particular treatment. Or it might not be a choice of treatments, it might be, this is more of a public health example. Suppose you've decided you're going to have a screening program. I guess there's a national breast screening program in Japan, is there? I'd be surprised if there isn't. But having decided you're going to have a national program for screening for breast cancer, you've still got lots of decisions. What age range are you going to invite to the program? For example, lots of countries start at age 60. Some start at 55. Some have an upper age limit. Initially, when breast cancer screening was introduced in the United Kingdom, we had an upper age limit of 65, because it was thought that over 65, women wouldn't really be very interested in coming along for breast screening. That wasn't evidence-based at all. That was just I think that was sort of 60-year-old men making some sort of assumption. We've now got to increase the age limit up to 70. You've also got an issue of how often do you invite. In England, we routinely invite women every 3 years. Some countries, it's every 2 years. In the United States, they don't have a national program, but the professional organization's recommendation is annual screening. we might be back to fee for service again, influencing that decision. You've got, is it two view or single view? You've got the mammogram, is it going to be interpreted by, well, a radiographer or a radiologist? Say it's a radiologist, are you going to have just one person look at each mammogram, or are you going to have a second person look at each one? Now, all of these choices are economic decisions to a large extent, because they all have the characteristic that by changing the age range, changing the screening interval, going for single view or two view, going for single or double reading, they all can let you improve the effectiveness of the screening. You can detect more cancer. But they all will involve more resources. So is it a good idea? You've decided you want a screening program. Sorry, I'm just adjusting my step counter. It is product placement. These Fitbits, they've got a life of their own. They sort of spring themselves free from your wrist every now and then. Does anybody else have a Fitbit? No? You're all too healthy. My theory is it's unhealthy people have Fitbits because they need something to remind them to walk. Yeah, so all of these interventions, they all got this characteristic that you could always do a bit more, get more effect, in this case detect more breast cancer, but you'll then take more resources to do that. And so these are all, to some extent, economic decisions. Now, I don't by that mean they're just decisions for economists to take. I don't mean that at all. But they are fundamentally economic decisions. They're decisions to do more of one thing in order to get certain benefits. And the implication, you're doing less of something else. And that's what economics is partly about.